Up next is Dr. Pedro del Nido from Boston Children's Hospital. He is the chief of cardiothoracic surgery out there. He has a very special interest in heterotaxy children, and I know there's at least 3 families that he has cared for their kids in our audience just today. So he is someone that is innovative when that's what our kids need. So we appreciate his time to come out here. We know that he has kids still in Boston that need him. So I'm going to go ahead and turn the floor over to him. Please join me in welcoming Dr. Del Nido to Heterotaxy Connection Conference.
I'd like to say, first of all, thank you very much for the invitation. It's always gratifying to me because I give a lot of talks, and almost all of them are really medical conferences where I'm talking a lot of very technical things to individuals who are basically have similar backgrounds. But for me, it's really a great pleasure to talk to an audience such as this who have a very direct connection to this topic because of either family members or themselves, and are interested in promoting more knowledge or promoting more investigation and advancement of the treatment of children with this kind of a problem. Heterotaxy is in many ways, at least for the cardiac problems, kind of like the forgotten problem. And the reason why I say that is because if you look at what's been published in the medical literature on the management of children with heart defects, you'll see very large series, lots and lots of patients, and at the bottom it always says, well, we excluded heterotaxy. And they weren't incorporated in the studies because they were so complex. They said, well, it really, they're too complicated for us to really analyze, and so they were excluded. And it always surprised me that people would do that, because at the end of the day, they still have a problem and we still have to address it. But nevertheless, that was to a great extent, and even today, that's how these things happen. And that's because people want to focus on the more common, the more straightforward things, and that's what they want to talk about. So I decided maybe about 15 years ago that really this is an area that needs some focus. It needs some effort to try to come up with better solutions. And what I'll try to do now is sort of walk you through a little bit about the evolution of how that came about, what heterotaxy is from the cardiac standpoint, how people have approached it, how they thought about it, what treatments were offered now, what people are thinking about now, and a little bit about what we're doing at our center, and some of the results. There'll be some technical stuff that you'll see. If you have any questions, just raise your hand. I'm happy to stop and explain, because I think it is important that you get a good picture of what's going on in the field right now, and what are the discussion topics that physicians, at least, and surgeons in particular, are really focusing on now. So I'll start off with how we think about heterotaxy. One of the problems that we've had all along has been the nomenclature. What do we call this? What do we call heterotaxy? And there are lots and lots of other defects which are not really heterotaxy, but somehow get mixed in. So in the normal heart and lungs, the abdominal and the chest organs have a sidedness. And so the heart, as we all know, is on the left side normally, the left side of the chest. The left lung has only 2 lobes. The right lung has 3 lobes. And part of that is because part of the space in the left chest is taken up by the heart. So there is a difference. Similarly, in the abdomen, the liver is on the right side. Typically, the stomach is on the left side, and so is the spleen. So what we call that is situs solidus, or normal situs, or normal position. You can have the mirror image of that. It's very rare. You can have exact mirror image of that, so that instead of the right lung being on the right side, the right lung is on the left side, and everything, it's almost as if you put a mirror to their organs, everything's inverted. And that's called situs inversus. There's nothing wrong really here with that set of problems. It's just simply a mirror image, and that's how the body was developed. But a lot of people confuse the situs inversus with heterotaxy. But really what heterotaxy is the absence of that sidedness. So that each side really is exactly the same as the other. And you can have two left sides, which is left atrial asomerism, two right sides, or right-sided right atrial asomerism. And basically that's what it is. If you look at the kids with the right atrial asomerism, or RAI, I think is the term that people like to use, they have two right lungs. Both lungs have three lobes, just like the normal right lung. If kids who have the left atrial isomerism, their lungs have both two lobes. So they're exactly the same. There is no sidedness. Well, what's the importance of that? The importance is that that orientation, that left and right-sidedness, really impacts the development of all the organs and how they connect with each other and how they form. So that kids who have this heterotaxy syndrome, or what some people use the term isomerism, means that both sides are exactly the same. It really impacts their abdominal organs as well as the heart and the lungs. The fact that the lungs have only two lobes versus three makes no difference. The lung tissue is there, works quite well. And so it doesn't really have any impact. On the heart, though, the fact that the chambers have to be there, that makes a big difference. And we'll talk about that in more detail. As we get into the abdomen, the liver is affected because normally the liver is in the right side, situs inversus is on the left side, but here it's in the middle. There's a liver that covers both sides. Well, it still works, so that's not a big deal. But the spleen is what's affected. So the spleen, it's a very specialized organ. It really filters out certain types of blood cells, white blood cells, which are important for your immune system. And in kids who have left atrial asomerism, they have multiple spleens. In kids with right atrial asomerism, they have no spleen. The importance of that, again, is more to do with their immune system than anything else. So as you can see, even though we pay a lot of attention to whether the kids have a normal situs or abnormal situs inversus, that is really of no consequence to them because it doesn't impact the organ function. When kids have heterotaxy, on the other hand, it does impact their organ function, and that's why they really need to be looked at a little bit differently. So just to recap, the right atrial isomerism, there's three lobes to the lungs. Left atrial, there's two lobes to the lungs. Also, the upper chambers of the ventricles are the atria, are also, there's a right side and a left side. In the atrial isomerism, you have either two right sides or two left sides. Again, the same pattern tends to happen. And in the abdomen, the small bowel, the gut, instead of having the normal rotation, because the gut makes very much of an S curve as the small bowel and the large bowel develop, they don't have that. And so they have malrotation. So the small bowel is sitting on one side, the large bowel is sitting on the other. It didn't normally rotate. The implications of that are that there is the potential for the bowel to twist on itself and to obstruct. And so sometimes we see that. It's rare to see a problem like that, but sometimes we do preventive procedures to pin the bowel so that it can't rotate. That's called a LAD operation. So this is an example. This is the situs solidus, which is the normal situation. The colon makes a circle around the small bowel. In inversus, it still makes a circle. It's just mirror image. But in the isomerism or the heterotaxy syndrome, all the small bowels in one place, the large bowels in the other side, and that's where the problem comes in. Well, what causes all of this? I'm sure you're going to hear something about the genetics of these diseases. No one really knows, but there's been a lot of advances in the last 10 years, I would say, in understanding why these things occur. And what they found is that very, very early in the development of the fetus, there is this orientation that occurs, and it has to do with where the embryo sits with the relationship to the placenta, and it's a very complicated issue, but it recognizes very early in its development that there is a side, and there is a left side and a right side, and then the two sides develop differently. And that's a very important process for the normal development of all the organs, and it's the loss of that ability to detect one side or the other, which causes these. And so you get these as the heart is forming, which initially the heart is a tube, then folds on itself to become the tube pumping chamber. And as it does that in the heterotaxy kids, what happens is it doesn't quite do the normal folding and the normal connections, and so it gives us a whole host of different problems inside the heart that then we have to deal with after the baby's born. Typically, before the baby is born, all of this, regardless of how scrambled the connections are, usually it doesn't affect the baby that much in the womb because the mother is oxygenating the blood through the placenta, and so the lungs don't really have to be connected. They don't have to work. Once the baby's born, now their lungs have to take over, and the circulation has to be well balanced, so you get enough going to the lungs and enough to the body, and that's when the problems start. So the actual cause, and this is a genetic study, this was actually where they recreated this syndrome in a mouse model. They think it's this important gene, this DNAIC1KO. This is all a work in progress. People are beginning now to really understand, and I suspect in the next 5 to 10 years we have a much, much better understanding of why this develops. Whether we get to a stage where we can do genetic treatment at all is a different story, because we first have to understand it before we can start to develop treatments for it. But this is the first step. This is a key step to really know that. So much more to come in the near future, but right now it's a research topic that's highly active. Well, how does heterotaxy fit in the whole spectrum of heart defects, and particularly those that we see in adults? Well, most of the patients with heterotaxy end up with complex problems, and so that accounts, this group with complex problems, this is adults with congenital heart disease. So now, once they reached 18 years of age, if you look at all the different defects that you can have with your heart, the complex ones account for about 15%. And within the complex one, heterotaxy is a relatively small component. So it's a rare lesion to see it, especially in adults. But you can see it. And their problems tend to be a little bit unique. And it does have to do a lot with how the heart developed to begin with. But we have a lot of information about how the heterotaxy patients do as adults. And we continue to follow these patients during their adult life as they go about their normal activities. So I'm going to focus now primarily on the cardiac problems, because that's my area of specialty, and so far I've been talking about other things that I read about, but it's not really my area. I'm very interested in heterotaxy, so I read a lot about it, but really this is the kind of thing that I deal with on a regular basis. So what are the kinds of heart defects that you can see with heterotaxy? Well, there's a whole host. And as you go through the whole cardiac system, you see that almost at every step there are problems. Very often there are abnormalities of the veins as they come back from the body or from the lungs and come back to the heart. Sometimes normally we have one big vein coming from the upper half of the body getting into the right side. Most of the kids with heterotaxy have two, one on the left side, one on the right side. So no real consequence as long as it connects to the proper place. Often it doesn't. When it doesn't, we have to fix it. The same thing is true with the pulmonary veins, the veins coming back from the lungs. They normally should come straight back to the left side of the heart. Some of the babies with heterotaxy syndrome, that doesn't happen. They connect via other connections, or sometimes they come back to the lungs, but they're obstructed, they're blocked. And in that situation, we see the problems very early in life, and we have to address those very early, sometimes even as newborns. Very rare, but when it does happen, it's a big issue, and it really impacts their long-term outcome. So that's just the blood coming back into the heart. The upper chambers, the atria, they're almost always abnormal, and they can have, the atria really is where your own native pacemaker of your heart is, what controls your rhythm. So when we have the abnormalities in these upper chambers, we can have rhythm problems, heart rhythm problems. So irregular heartbeats is quite common in children with heterotaxy syndrome. Most of the time it's fairly benign. It doesn't cause real problems, but occasionally they can go into really fast heart rhythms, and that can cause problems. So it's a separate set of issues that the electrophysiologists deal with on a regular basis with medications, sometimes with catheter interventions, and occasionally we actually intervene surgically to try to treat these arrhythmias. The inlet valves are very, very frequently abnormal. Normally we should have an inlet valve onto the right side of the heart, an inlet valve onto the left side of the heart, and they look different. Babies with heterotaxies, the valves can be quite abnormal. They can still have two separate valves but look abnormal, or they can just have one common valve that straddles both sides. And what we end up having to do, if we're going to try to fix that, is to partition that valve from one large valve into two separate valves that work well. And then the actual pumping chambers, many times the babies have two good size pumping chamber, two good size ventricles, but sometimes they don't. One side is favored over the other. And so we have a smaller one side than the other. And then we have to think about what else can we do to manage those babies. And then there can also be in the outlet, the blood going out of the heart, abnormalities there. So as you can see, at any point in the process of the circulatory system, you can see abnormalities. And the thing about the heterotaxy kids is that they don't all have everything. Some kids will only have problems with the veins. Some kids will only have rhythm problems. Everything else is normal. Some kids will only have valve problems. And so it can be any combination of the above. That's why no two children with heterotaxy are exactly the same. They're all slightly different because they have different components of this. And so if you are going to treat and you're going to manage kids with this problem, you really have to sort of be pretty systematic. You've got to go from A to B to C and so forth, and looking at all of the components in order to make a plan as to how you're going to manage these things, fix them all as the kids get older. So I'm going to walk a little bit through that as to the details as to what's special about them and what do we do about it. Here's just a schematic of the wide variety of changes in the inlet valve. Normally we should have two inlet valves. This is the pumping chamber, the ventricle. This is the right side, this is the left side. The E's up here are where the blood comes in, the upper chamber is the atria. So these valves that are right here, they look like little gates. They let the blood in. When the heart squeezes, these little gates close, and they don't allow the blood to go backwards. And that's how it should be, so that the blood can be pumped out, either to the lungs or to the body. What happens here in the normal situation is that there's a very specialized valve that looks different on the left side compared to the valve on the right side. Well, the heterotaxy children can have that. I've seen certainly children with completely normal valves, but more commonly they have what we call a common AV valve, which is one large valve that straddles both sides. They can either have equal sized chambers with one large valve, or one side is favored over the other. In this case, it's the left ventricle that's dominant or larger than the right ventricle, all the way to this case where there is no right ventricle. There's only one pumping chamber. Similar on the right side could be dominant, all the way to a situation where there is no left side. Sometimes it's termed hypoplastic left heart syndrome. So this spectrum is what we often see. The way we look at the valves is echocardiogram. It's an ultrasound that gives us a view not only of the size of the chambers. This is the left side, this is the right side, this is the atrium, the upper chamber, and these things moving around in here those are the inlet valves. And in this child, they have one big huge valve letting blood into both sides. And so this is how we begin to analyze. We begin to look at them, and typically the ultrasound is the best way to look at the valves themselves. The other advantage is it's not an X-ray, it's not a radiation, it's safe, it can be done as often as you want, and most of the time it gives us all the information we need to assess the valves themselves. So we don't need to do invasive tests like catheterizations, except in the situations where we really need information about the pressures or some other specific information. Most of the time the ultrasound gives us all the information that we need in order to figure that out. we can hone in specifically on the valve. This is the same valve, except we're just looking at on the face of it. And what we can do is we can actually see how the blood is going in. And this yellow flame that's here is actually blood leaking backwards. So the ultrasound can tell us not only what the valve looks like, but it can also tell us, well, this valve is leaking. Not only is it leaking, it tells us exactly where it's leaking, so that the surgeon who's planning the repair said, oh, okay, that's the area I have to focus on because that's where all the leak's coming from. And so you can plan your procedure. And so this is why the ultrasound is so helpful for us, because it not only gives us information about how the blood's coming in, what the valves look like, how big the chambers are, how the valves are working, which is quite important. And that helps us plan the operation. And then when we get into the actual operation, we know pretty much what to expect. And this is an example of a valve that has a split in it. This was the cause of this is the heart. This is as we're looking at from the upper chamber, from the atrium, we're looking into the pumping chamber, and we're looking at this valve that's there. And this valve, normally this tissue should be one big sheet that opens and closes. This one has this split in the middle, and that's the cause of the leak in this case. And that's how we do the analysis in the operating room. But we like to know ahead of time whether that valve is working, because here there's no blood. We're on a bypass machine, we've stopped the heart, we've emptied it of blood, so we can't really tell very easily where exactly the leak is. So all we can do is we can see the anatomic defect, but the echo tells us exactly where the problem is. So we always put both pieces of information together in order to decide what to do as far as the repair. So what you've seen so far is the complexity of the problem, how it can impact all of the different structures of the heart. So what happened very early on when surgeons were trying to figure out, okay, what do we do about this? How do we treat it? Often what happened was we said, well, what's going on inside the heart is very complex. We've got valves, we've got holes, we've got outflows that are obstructed. You know what? There are operations that we have that we know how to do that are much more straightforward, that simply bypass this whole problem. And so if you manage the whole structure as one big pumping chamber, regardless of the number of valves, regardless of the holes, then what you do is you stabilize the children initially when they're born. If they need something, you do some initial palliation. It can be a shunt to provide more blood flow to the lungs. If there's too much blood flow to the lungs, you put a band to restrict it. If you have problems with the veins, you fix those. But above and beyond that, you don't do anything else. But when the kids get a little bit older, then you start managing them as if they only had one pumping chamber. And that's a staged reconstruction. Typically this Glenn operation, and I'll show you a picture of that in a second, is done somewhere at around 4 to 6 months of age. And then when the children get up to be about 2, 3, 4 years of age, then we do what's called the Fontan operation, which essentially bypasses the whole right side of the heart. So the blood coming back from the body goes directly into the lungs, doesn't enter the heart at all, in order to pick up oxygen. And whatever pumping chambers you have, whether you have 1 or 2, takes care of the blood that's been oxygenated and pumps it to the body. It's a solution, but it's not a physiologic solution. But that's how we started, simply because it was a much easier operation to do, and we knew a lot about it. We were doing this operation on hundreds and hundreds of kids with other types of single ventricle problems. We knew when to do it, we knew how to do it, and we knew what the results were going to be. And so it was applied to heterotaxy. Over the last 10 or 15 years or so, we've been revisiting that decision, and I'll show you why. But we've been trying to come up with ways to, in the majority of the kids, achieve 2 ventricles and 2 ventricle physiology, which is the way your body should normally work. It isn't always possible, but what's required if you're going to do that, you need to partition the inlet valve, so you need to make that big valve into 2 little ones. You need to separate the chambers, because there's often holes between the 2, and you need to establish outflow connections that are normal. So all of that has to be done. Several steps, big operations. So that's why it wasn't done initially. So this is what the staged palliation, the so-called single ventricle management is. you basically treat the heart as if it's just one solitary pumping chamber with one valve. The Glenn operation is where you take the blood flow from the upper half of the body, connect it to the lungs. So that's the first stage, again, typically done at 4 to 6 months of age. And then the Fontan is where you take the blood flow from the lower half of the body and plug that into the lungs. So now everything coming back from the body, the blood that's given up its oxygen, coming back and goes directly into the arteries going to the lungs to pick up oxygen. That's the Fontan operation. So it's done in stages typically, aside from the newborn, stage 1, where you do whatever is necessary to stabilize the children, and then you start moving them along this single ventricle pathway. Well, what are the results of that? Well, early on, the results were really quite poor. And if you look at this chart, this is a study that's 9 years old, and they went back 15 years to look at their experience. So it's a bit historical. But this is a survival curve. This is the overall survival. And what you're looking at is the age in months from the time of surgery up to 120 months, so essentially 10 years out. And the survival percentages on this curve, what you see is that within the first few months, over 50% of the children didn't survive these operations. Okay? And if you began to break it down and just to analyze, what they did was they looked at which ones did better than others. And what they found that if you got past the first 30 days of age and you started doing these procedures, they actually did a lot better. If for whatever reason you had to start doing surgery before or as a newborn, those are the children that really didn't do well. Well, this is a little bit historic. The data has gotten a lot better, and the reason is because two things. One is we've learned to do these operations a lot better. But the other part of it is that people have become much more selective as to what they offer. And so if we know that certain children are at high risk for the Fontan operation, often the Fontan wasn't offered to those kids. And so what it does is, yeah, the survival now at 15 years out is about 80%. Think about that previously. Before, less than 50% were alive at 10 years. Now this is a newer study, much more recent data, 80% are alive at 15 years. So huge, huge strides. But part of that is because a lot of kids were excluded from this kind of therapy. So that's where the problem comes in. If you're thinking about the Fontan as a way to avoid lots and lots of operations, that wasn't the case. And in fact, when we looked at it, in our experience, about a third of the kids needed some follow-up operations, mostly work on the valves. And as far as rhythm problems, this is the freedom from arrhythmias, and about 50% of the kids by 7 or 8 years had some sort of arrhythmias that needed to be treated. So those were the cardiac problems with the Fontan, and there are other problems with the Fontan operation late, and that has to do with the fact that it impacts the function of the liver and it impacts the function of the kidneys. And what we're finding out now is we see these no longer children now, they're adults, and they've grown up, but they've been living with this Fontan physiology for 10, 15, 20, 30 years. Now we're beginning to see the complications of the Fontan operation, and things like protein-losing enteropathy, coagulation abnormalities, plastic bronchitis, these are in cirrhosis of the liver. These are all things that we're seeing 20, 30 years down the road. So this is what was the impetus for us to start looking at other ways to manage kids with this kind of problem. Was that, number one, yes, we could get the survival a lot better, to look a lot better, but that was by excluding a lot of kids that were high risk. But also, even the ones that did well with that approach really had problems long term. So you kind of kicked the can down the road, really. You didn't really solve the problem. So it started us thinking about, well, what else can we do? What can we do as far as the two-ventricle repair? So in order to do that, we had to develop techniques to deal with the valves. We had to make sure that the ventricles were equal size, and if they weren't, we call that balanced. In other words, that they're each side is the same size. If they weren't, we needed to figure out a way to get them to grow. So get the small one to grow so that it actually became about the same size as the other side. And then we needed to figure out ways to connect the ventricles to the proper arteries. And that Fortunately, this part had already been solved, and there were lots of techniques to do that. The valves, we actually borrowed from techniques from other more common diseases to fix that. There's a much more common problem called an AV canal defect, which is very similar as far as the way the valves look in heterotaxy, but these children don't have heterotaxy. They just have isolated the valve problem. And so we borrowed the concepts of repair from that group of patients to come up with a whole variety of approaches to fixing these valves that now work pretty well. The issue of the balance, we borrowed actually from our experience. We've been looking at ways to get ventricles to grow in babies that are born with only one side, where the second side is very, very small. And what we found is that there are ways, if you can force blood to go into those chambers, they can actually respond in small children. They're growing so fast that if you force a little bit more blood, those chambers really grow. And as long as you can do it in a way that really gives some impetus for its growth, you see a response pretty quickly. And the younger they are, the faster they respond. So we borrowed that concept in order to address this, which is the lack of balance. So in kids where the left side was dominant, we were able to force more blood flow into the right side to get that to grow. And the inverse of that, for kids where the left side is small, force more blood into the left side in order to get that to grow. And then just wait. Let the force of the blood flow get that ventricle to grow to normal size. And so the strategy was we would still treat them as if they were a single ventricle, but forcing more blood flow into the small chamber, and then at some point convert them back to two ventricle repair whenever that chamber achieved the normal size. That was the strategy. We borrowed from this experience where we were treating children with hypoplastic left heart syndrome where the left side is completely small, and we started actually treating those kids in the fetal stage by catheter methods. And we now have, this is our experience with the first almost 100 of these patients, and a large proportion of those kids were able to achieve two ventricles. So this is not heterotaxy, but we borrowed the idea to apply it to the heterotaxy. And then we began to see what the results were. So we wanted to extend this concept to induce the chamber growth. We went after the moderately hypoplastic, not severely hypoplastic, the unbalanced canals, and we wanted to achieve it, or to apply this to the heterotaxy. Well, what we found is the heterotaxy kids responded just as well. And so if you look at, on this graph, this is before we started to try to recruit in this case it's the left side of the heart, and after, and this is the size of the ventricle here, virtually all the kids responded. And so as long as you start at a young age, and typically that means under 2, 3, 4 years of age, this seems to work in the vast majority. So we came up with this management strategy, which we use. And so if you have mild small chamber, often we will try to do, as a primary repair, go to the two ventricle repair. In those that have moderate hypoplasia or moderate small chamber, then we undertake this recruitment step. And in those kids, we do a staged approach. As that ventricle grow, then we'll move them over to the two ventricle repair. And then there's always a group where things are just way too small and this isn't going to work. And so those kids we manage with Fontan operations. And so that's been our approach over the last probably about 7 years. This is the results of the overall group. This is all the kids treated, whether they were treated with two ventricle repair or Fontan. And we don't have as much follow-up because this is a relatively new treatment. We have up to 6-year follow-up. About 80% of those kids are alive. And about 50, maybe less than 50% at 5 years are free of re-intervention. By that I mean either catheter or surgery. So not too bad, still a work in progress. But then we looked at which ones did better. And in this curve, the color codes are, in blue is the kids who we felt had too small a chamber, we had to do the single ventricle management, the Fontan. And their survival was by far the worst compared to the two other two groups where we did the two ventricle, whether it was as a primary operation or as a staged, they did equally well, and they seem to do better. This is our experience. This is a work in progress. It's not, I would say, it's not ready for everyone to start doing this, but we keep accumulating our experience, and we keep reporting our experience, and we want to see other centers do this and see if in fact they get the same results. But for us, this has been the main driver to continue this project, to continue doing it this way, because at least in our experience, it seems to offer a better chance for the kids. So to summarize, what I've talked about so far is heterotaxy syndrome of the heart. First of all, has a wide range of defects. It's very complex, and it has multiple facets. It often involves all different components of the heart, and the options for management are really, we can manage them as single ventricle, or we can manage them as two ventricles. We have to be selective to some degree, but the strategies that we take really depend on what anatomy we start off with. The biggest risk factors continue to be abnormalities of the pulmonary veins. That seems to be abnormal pulmonary veins or obstructed pulmonary veins, continues to be a big challenge for us. And the other big challenge for us is the arrhythmias, which sometimes can be quite difficult to manage. So just to summarize our approach, we do use the single ventricle, the Fontan, for very hypoplastic ventricles. We try to do stage recruitment for the kids where the ventricle is moderately small. And in those where it's only mildly small, we'll go directly to the two ventricle repair. What we found is age makes a difference. Some of these operations, if the children are a little bit older, they seem to handle the operation a lot better than if you try to do it in children that are only a few months of age. And so we often try to get them a little bit older and then go to the two ventricle repair, and they seem to just tolerate that operation quite a bit better when they're a year and a half, 2, sometimes 3 years of age, than if we try to do it at 6 months of age. So that part we've learned, but this is our current protocol. Thank you very much. Be happy to answer any questions that you have. Yeah.
Maybe this hopefully was not too big of a question, but I'm curious about in the days and weeks after Operation Single Vent versus a Bivent, what are the most common
Kind of complications? Yeah.
that you see with heterotaxy?
So they're very different, whether you're doing the single ventricle or whether you're doing the biventricular repair. For the single ventricle, the most common problems that we'll see are the arrhythmias, and also problems, the way the Fontan works, since there's no pumping chamber forcing the blood through the lungs, it's only the pressure difference. The pressure difference is what drives the blood through the lungs, so the pressure in the veins jumps up as soon as you do it. And that impacts the abdominal organs, the liver, the kidney. Kids tend to retain a lot of fluid, and so that's the biggest challenge with the Fontan. Most of the children adapt within a week or two, and then they're better. They need a lot of medications early on, and you can usually taper those later on. But the arrhythmias and the fluid and the fluid retention and the impact on the organs is what we see for the Fontans. For the biventricular repairs, it's because the complications are twofold. One is from the valves. Now, it's if we didn't repair those valves, if we didn't partition them well, and one of them, let's say, is leaking, that can give us problems. Or the other is if that chamber that we were getting to grow hasn't quite reached its full size, it's going to struggle. And that's the other situation where kids can get really stuck. So the timing of that two ventricle conversion is really critical. We don't want to wait too long, but on the other hand, if we go too soon and that chamber is not ready, then we have a problem. So that's the other complication you can have. We've gotten a lot better at predicting when to do it. So really the one problem that's probably the most common is just the valves. Either the inlet valves or the outlet valves that are the ones that continue afterwards. So. Okay, I hope that answers your question. Okay, thanks. Yeah.
I just had a question when you were talking about like growing the ventricle.
Mm-hmm.
And I heard you said blood flow. Like, what is that process actually? How do you do that?
So, yeah, that's a good question because that's the key to all this. What we found is that because the kids have a sort of one large valve, if that valve is oriented mostly to one side or the other, it's wherever that blood flow goes in, that's the chamber that grows. Wherever it doesn't go, that chamber stays the same size. The reason why our children go from little size to this size and their heart grows with them is because they just have more blood flow. You know, physically, if they get bigger, there's just more blood and more flow pushes those chambers, and they respond by growing. By the time we get to be about 18 or 20, that stops. We can't do that anymore. There's a little bit of growth, but very little. So what we did is we took advantage of that and partitioned the valve and partitioned the upper chamber so the blood that comes into one side can only go into that chamber, and the blood that comes to the other side can only go to the other chamber. And so that forces blood into the chamber that was sort of neglected, if you will, and that's what gets it to grow. And the key has been, and this took us a while to figure this out, it's just how hard do you push? In other words, how high do you let the pressure get before you start to get into trouble? And that actually took us quite a while to figure out what's the right balance. Now I think we've got it pretty well solved, but that was not a simple problem. But that's the idea. So we partition the upper chamber, split that valve into two, so that now the blood has to either enter one side or the other. And so each chamber that's receiving the blood, if you balance those, then it'll grow, it'll catch up.
And typically, at what age do you start doing that then, if that's a possibility?
We like to do it, ideally the younger the better. You know, what you're trying to take advantage of is the fact that little babies are growing so fast that it doesn't take long for that chamber's growing anyway. You're just basically trying to get catch-up growth, you know, trying to catch up to where it should be. So ideally we'd like to start at a few months of age. I've done it in, you know, the oldest child that we've done it has been 14 years of age. So you can do it, but it's a huge struggle. And it takes years for them to get to the stage where a little baby will take 6 months to get to. Okay? So at some point you lose that ability. And where you lose it, it's hard to tell, but our general approach is if we can start before 2-3 years of age, those are the kids that have done the best. Once we start later than that, we start to struggle. Okay. Yeah.
So is that why if their ventricles are too small, you can't grow because the pressure gets too high? I can't explain the last one. Is that the reason why those kids won't qualify for a Biventricular?
Or if the chamber is just, I mean, there are kids where the chamber is just absent. You know, it's just there's nothing there, and it's uncommon, it's unusual, but yeah, we see that. We see kids where there's just no chamber there, and then there's nothing really to work with. So you have to start with something. You know, it may be half the size of the other, but it's got to be at least kind of like half the size. If you have something that's 5% of the other side, that's not going to work. We can't do that. So that's usually where we kind of draw the line. Okay.
And do you feel like Boston's known for, you're known for doing the Bivens, and other hospitals say no? Do you feel like Boston is just more confident, that you yourself are more confident in the ability? Why do more hospitals stay with the Fontan route versus considering the Biven?
Yeah, that's a good question. I mean, I think in order for us to get to where we were, we had to develop techniques for all those things. In other words, partition the chambers, partition the valves, fix the valves, and get the chambers to grow. Not everybody's comfortable doing all those things. And if they're not experienced at it, they shouldn't just jump in because you're going to have a lot of problems. So that's why we've been trying to get the techniques, explain to people what the techniques are, and now there are other centers that are starting to do that. And they're starting to do components. For example, there are lots of groups now that are partitioning, figuring out ways to partition these valves and getting good results. That's now becoming much more common. I think the growing of the ventricle is probably the one that's going to take the longest. It's just conceptually, it's something that for whatever reason, it's been hard for people to accept. But it'll come. I think people, once they see it themselves, I think they'll be convinced. So, yeah.
So our child will be 3 in November,
Mhm.
and they're headed for the Montana next summer. But we were in the beginning told she could be a 2-ventricle,
Mhm.
and then we were told she has a lot of plumbing, but she has 2 good functioning ventricles. So how late is too late to look at a biventricle repair? Should you receive records and decide she could be a 2-ventricle?
Yeah. Well, if you don't have to grow the chamber, you know, the issue of the growth is age dependent, because the younger they are, the more likely they are to respond. But if the chamber is already a good size, you know, if both sides are good size, then it's really mostly, as you said, it's an issue of plumbing. You know, how can you get these veins to that side and those veins to that side, et cetera, et cetera. And that's very, very dependent on the anatomy of each child, and each child is a little bit different. So you have to look at all the imaging studies, the echo, the cath. If they've had an MRI, that's very helpful too. So look at all that and then put it all together and see, okay, is this feasible, first of all? Can we get the blood flow to go to the right place? And what's the risk involved? So we look at what's the risk of that versus the risk of the Fontan, even taking into account the long-term risk of the Fontan. And then you kind of have to weigh the balance. So that's how we basically do it. So in that situation, if you start off with 2 chambers that are equal size, then age is not as critical a factor. It's really mostly, you know, what is it going to take to get from one side to the other. A lot of the kids that we do these so-called biventricular conversions on, we're taking down Glens, we're taking down Fontans and reconnecting things. So that can all be undone. What's hard for us is to actually get to grow the chamber. So if they already have the balance, then you're a good ways there already. So, okay.
Are there situations where a biventricular repair is attempted and it's proving not helpful for the child? Can you go back to single ventricular
Yeah.
repair at that point?
Yeah. It's hard, but we certainly have done it. And at that point, one of the things we have to start considering is transplantation a better option for them? Okay? So if for whatever reason the biventricular repair is not working, whether it's the chamber is too small or the chamber just, it may be size-wise may be okay, but just too stiff and not allowing the blood to get in, then you can go back to the Fontan or think about a transplantation, because there the sort of risk-benefit you know, is about equal. And so it's one of, I mean, the hardest thing about transplantation often is just getting a donor. And so if you can get it, then kids can do very well long term. So that becomes the other alternative in there. So, okay. Yeah.
I'm not sure if I heard you properly when you just answered someone else's question. You said you've gone back and undid a Fontan and turned it into a vine.
Yeah, we've done that. Yeah. It's been the only times that we really have done it is when kids are failing the Fontan.
Fontan was failing.
Right. Because they're not, when the Fontan fails, there's not too many options. You either go for transplant or you do, something else, the biventricular repair. To take a child who's doing very well with a Fontan and try to do a biventricular, you're doing a huge operation with a risk. To do that on a child who's really doing well, it's hard to justify that, and I'm not sure I would recommend it, frankly. But the ones that we have experience with it's usually the children have one of the list of complications that I showed you. They have that. And we know that once they get protein-losing enteropathy, once they start coughing up casts or they start to have liver dysfunction, we know this is not going to last for very long. So those are the kids that we've if they were candidates for it, we've offered them the 2-ventricle and have taken down the Fontan and gone down that route. So, yeah.
You said pretty much your guideline is 50% of the ventricles being because we have hyper left and it's pretty extreme.
Mm-hmm.
So I don't know if our one ventricle is 50%.
Yeah, it really, I mean, each one of those you have to individualize. You have to see what the actual size is. okay? Because in some cases it won't be. If it's too small, to really try to recruit it is a long and very risky road, and usually not worth pursuing unless there's some very specific reason to, and so we wouldn't recommend it. But if you're sort of halfway there, those are the kids that our experience have done relatively well. As long as they're relatively young, you can get it to grow. Okay. Yeah.
Curious when you start, like when did you start doing biventricular repair? How old are those kids now?
Well, we try to start as early as possible. So we try to start in the first few months of age.
No, but how, when did you start actually using the biventricular repair versus the single ventricle?
Oh, I mean, like how old is the oldest? Oh, I think about 14 years ago is what was our first one, and still doing fine. So, but not all of them have. As you saw the numbers, about 15-20% have not done well and either required a transplant or didn't survive. So those are kind of like the numbers. Okay. Yeah.
All right, and wait, do you want to go ahead?
Yeah, just one question. Going to the plateau route, what is the oldest people wait to do the contact?
Well, so for the Fontan, typically most centers like to do it between 3 and 4 years of age. You can do it a lot younger. We've done it as young as 10 months of age, but only in cases where you really had to. There was no other option. But most of the time, the ideal age is somewhere around 3. A lot depends on the technique that people use. Some people use this extracardiac tube, and so for that, since it's a non-growing tube, they like to have the kids a little bit older, a little bit bigger. We don't use that technique very much. We use their own tissues, so we can do it at 2.5 years of age. That's the ideal time. Yeah. Yep. Yeah. Yeah.
I had a few questions. First off, you were talking about the long term, well, you were talking about your older bivens. So what complications are you seeing from the bivens? Because we already know pretty in depth what the long-term implications are of the Fontan, and we know that our kids are even higher risk for them than the normal population.
Right.
So what are we seeing in the biven? And do you know specifically heterotaxy? What is heterotaxy?
Yeah, yeah, that's a good question. So the most common problems have been the valves. Both the inlet valves are probably the single most common one. So having to go back and re-repair those valves and occasionally replace them, that's been what we've seen in some of them. And as you saw the reoperation curve, by the time you get out to be about 6 years, a large percentage of them have had some other surgery. Some of the babies, they have an absent connection. For example, they don't have any connection to the arteries going to the lungs, so we have to put one in as a young child. They'll outgrow that, so we have to go back in and put in something larger as they get bigger. And those are conduit changes. So those, for the heterotaxies, I would say that's probably by far the most common. It's the valve issues.
The second question is, and it might be an interesting question, is that at one point, I know that Boston is working very heavily with the single vent, left vent recruitment. Is at what point do we anticipate this procedure or this staged path getting its own nomenclature that's recognized? Because we say bivent, and we know that we're talking about taking what we've got, should have maybe in most centers would have been Glenn Fontan single vent, and we
Right.
are we know that we are taking that and transforming it into 2 functioning ventricles. However, if you're talking to other centers and you say bivent, and they're like, oh, we do bivents all the time because when they finished, they had 2 ventricles functioning.
Right, yeah. Yeah, no. Yeah, so the terminology we have used is biventricular conversion. So we're converting kids from sort of single ventricle management to 2 ventricle management. So that's the terminology that we have used because of that confusion. Yeah, I mean, if you take a child with 2 good ventricles and you fix a hole in their heart, yeah, you end up with 2. Yeah, that's not what we're talking about. You're talking about kids that people thought single ventricle management was the only option. They went down that pathway, and then now you switch gears and you take them down. So it's a conversion to the two ventricle.
Okay,
Yeah.
fantastic. We'll start using that terminology.
Okay, okay.
And my last inquiry is, and maybe some here want the information, second opinions.
Mm-hmm.
How would you like us to best go about those? And next thing you and your team out there in Boston. And
Right. So really the best way to do the second opinion is to talk to your own doctor and ask them to contact us. That's really by far the best way. And the reason for that is we'll get all the information, and more importantly, that your home doctor is going to continue to see your child even if they come to Boston and you go back home. They're going to continue. So keeping them in the loop is really important. So ideally, that's what we'd like to see. We often have parents just contact us directly. We have a website. You just go to the website, and there's a second opinion button. You click on it, and it asks you a bunch of information, mostly contact information, a little bit about what the problem is, and then someone will contact you and ask you for specific information. But really, the ideal way is if you talk to your doctor and then they contact us. That's just it just keeps them in the loop, and you know, in the long run, it's going to be better for your child if they're knowledgeable of what's going on from the beginning. Okay.
I'm finished. I've heard in speaking with other families, this phrase that we've heard a lot and gotten different opinions, so I don't know how loaded of a question it's going to be, but we've heard the term, a good single vent is far superior to a bivent that's not perfect. That's not exactly the right word, but that's the idea.
Right.
And,
Right.
and the question I have is, how good does a bivent have to be better than a single vent? Well, from what you presented to us, my thought is, as long as it's going basically as planned, it's always going to be superior to a single vent. But
Right.
it depends on the
The key is what you just said, as long as things go as planned. So, you know, anytime you have a bad result, whether it's from a Fontan or the biventricular repair, it's, you know, you can't change that fact. So to say that a good single ventricle is better than a bad two ventricle, I would absolutely agree with that. That makes perfect sense to me. You know, the inverse is also true. A good two ventricle is better than a bad Fontan any day. But so really that's not the best way to look at it. Really the best way to look at it is that each child is, you know, we think that there's a really individualized approach to each child, because some kids are going to be great candidates for the two ventricle repair, and it's a no-brainer really to go down that route. In some, it's a little bit of a stretch. In others, it's way too risky, and it's not worth taking that route. And so to say something that, you know, is sort of broad and, you know, like that, it's not helpful. You really need to look at each individual child, because as I showed you, it's a huge spectrum. And some kids are great candidates for one, and other kids are much better candidates for the other. Unfortunately, the majority are in the middle. And so it's not clear as to which is better. And that's where a lot of thinking goes in, and a lot of planning, and you know, we do know there are certain risk factors for the Fontan. We also know, we're learning what the risk factors are for the biventricular repair. So as we get more knowledge, and this is where really it's kind of an evolving process, we're getting better and better and better at selecting which ones should go where. In the past, we were very good at selecting which ones went to the Fontan. The problem was the kids that we didn't offer it to, we didn't offer anything else. And so that was it. That was the end of the road. That's different now. We've got many more options, and so no child should go without something. It's just really the key is tailoring it to what they need. And that's really what this is about. So, okay. Yeah.
From so many other families, I've always heard of you and your interest of heterotaxy.
Mm-hmm. Mm-hmm.
My question is why? Why did you?
Why did I take this? I've asked myself that question many times.
I think I'm in a spot that I've been stable for a long time.
Yeah.
But I see so many families struggling, so many
Yeah.
situations
Right.
My cardiologist, I mean, she understands exactly what I ask her, same for my Cildren and everything. But I feel that some other parents are struggling to find someone to care for their kids as
Yeah.
they did. And then so many times I heard your name and they're going, no, go to the Nido, go to the Nido. I'm like, okay. It's
Yeah.
just, I mean, it's kind of amazing, but I'm like, I see so many other doctors running
Yeah.
away from heterotaxy.
Yeah.
And it seems like you are just good.
Yeah. Well, in part it's because of that. I mean, as I said at the beginning of my talk, you know, it's sort of been the forgotten disease. Because as you looked at all these big, wonderful studies, great results, it's always at the bottom in the small print, we excluded heterotaxies from this. And part of that is because of the complexity. It's just as simple as that. It's because of the complexity, clinicians shied away. They wanted to solve the other problems first. And when you're starting in a field, I mean, pediatric cardiac surgery is only about 40 or 50 years old as a field. And so they had big challenges, just very simple operations, which today we do routinely. In those days, kids died from those. So they had big challenges, and that's what they tackled. But as we've gotten more and more knowledge, and as the results have gotten better, we started to look at these. And for me, the heterotaxy was sort of the last big challenge, because it has so many components to it. And you really, it's not just learning one technique to fix that one problem. It's half a dozen techniques, and you really have to perfect all those. So for me, that was the interest, because I knew that if we figured out ways to fix some of these valves, we'd be a whole lot better fixing all the other valves that we see, which are a lot less complicated. So I think it helps everybody. So that's been the approach.
Have you got any gratification from that?
Of course.
I
Yeah.
mean, what will be your biggest satisfaction of this journey with heterotaxy?
Well, I saw a couple of them running around here. That's got to be number one. That really is. It's the fact that they are running around, and they're like normal kids, and that's really the goal. I mean, that's really what this is about. So that's the biggest satisfaction. Yeah. Yeah.
Changing the subject a little bit. So for my daughter, we're not sure if Fontan, we know Bivent can work. Actually, we had a second opinion from you, and Bivent is not an option.
Mhm.
So we're looking at a single lung Fontan
Mm.
or nothing at all.
Mhm.
And I guess, I know it's hard without specific medical records, but what are your thoughts of one lung Fontan or no Fontan? Because the thought is that the one lung Fontan might not help her at all,
Mhm.
and then we just pursue another open heart surgery for nothing.
Right, right. Well, we do have a limited experience with one lung Fontans in situations where that was the option. That was, you know, and they can work. And we certainly have kids. We've got a whole group of kids that we follow for years, and seem to be doing fine. Certain key things is if the one lung is lost early, either because the pulmonary veins are obstructed or whatever the cause is, in kids who are growing, the one lung that's working often compensates. It kind of like hypertrophies. It becomes much bigger than what they need and what it normally would be. And that is what allows us sometimes to do it. So there are a lot of reasons why, but can it work? Yeah, we've got lots of kids where we've done it. You have to be very careful, though. You need to be sure that all of the criteria that you need for a Fontan to work are there. Cutting corners will not work there. In many of the Fontans, people, you know, there used to be what's called the 10 Commandments for when to do a Fontan. This was when Francis Fontan came up with these 10 Commandments, and he came up with those. Well, we violated those commandments very, very early on. We figured out a lot of them didn't really matter, but some of them really do. And if you violate those, you're going to have a problem. So in each child, that's what you really are trying to assess. You're trying to assess, do they fit the criteria? And when they don't fit the criteria, is it something that really matters, or is it something that's really important? And if it is that, then you need to think of something else, and either not doing the Fontan, trying to keep them going the way they are, think about transplantation. You know, there's other options there that you need to keep in mind. Okay. Great. Well, thank you all very much. It's really a pleasure to be here. Thank you.